This is chapter 22, Principles of Drug Administration, which starts on page 266 of your patient care book. When they start off talking about this chapter, they talk about the 5 rights. And when we're preparing to administer drugs, as a tech, you always have to follow the 5 golden rules of drug administration, and they're commonly called the 5 rights of drug administration. They start off telling us that we have to understand the appropriate dosage, the side effects, the contraindications, safe injection practices, and potential adverse patient reactions once a drug is given. When they reference the 5 golden rules, they are the right drug, the right amount, the right patient, the right time, and the right route. If we look at each of those individually, when they talk about the right drug, you want to make sure you read the entire label on the drug that you're giving, and you probably want to do that multiple times. You want to make sure that you check the name of the drug carefully, and you check that label again 3 times. Typically, the first thing you want to check after you make sure that it is the right name of the drug, you want to check the expiration date. If the date is expired or it's very close to expiration, you will not use that drug. You would just report it and set it aside. They do warn that the names of different drugs sometimes sound very similar. So again, once you are going to give that drug, you want to make sure you check the label and make sure that that is the right drug that you're about to give the patient. If you're preparing a drug for someone else, you always want to show the container to the person that is giving the drug. That way they can make sure that you drew up the right content. You don't want them to just trust that you did that. And you always also leave the bottle out. As long as the patient is there, you never really get rid of that until the patient has gone left the department. That way, if there's any question about anything, you have where you obtain the drug from right there at your access. And you never ever use a drug if it has no label on it, or if you're unable to read the entire label on the drug. As far as the right amount, you want to make sure that the right amount of the drug is used, and in order to do that, it has to be carefully measured and it has to be accurate. If any of the drug remains, do not put that back into the original container. You're actually going to dispose of it according to the institutional policy. You want to check department protocol and make sure that the correct amount is given for the particular exam that you're drawing the drug up for. As far as the right patient, you are going to have individual protocol for the institution to make sure that you have your patient identifiers before you give a drug. You want the patient to repeat his or her name. You want to read the patient's identification number and medical record number, or have the patient confirm their date of birth as it's printed on their armband. And if the patient is too young to speak or is unable to speak for some reason, you want to ask a parent or someone else to present, someone else that's present, to identify the patient. You just don't want to randomly give the drug to the patient. So if it's a child, you want to confirm with the parent. If it is someone that is not able to give consent, you want someone else in the room to be able to give that consent and confirm that that is who the patient is. And if they're able to speak, just ask them to confirm their last name and date of birth. It's typically what department protocol says. Again, with the right patient, if their name or any other identifier as their date of birth or something along those lines does not match, then you have to stop and get the appropriate correction made before you continue with the procedure, and you do not give the medication. Once the patient is correctly identified, then you explain the use of the drug to the patient and how it's going to be administered for the exam. As far as the right time, the physician or the practitioner that's responsible for ordering the drug usually determines the right time of administration. Generally, the radiographer does not determine the time, but we administer the drug at the specified time. So if it's to be given at 10 a.m., that is usually the doctor's call as to the time that it's given, but we might be the ones to actually give the medication. Once the drug is given, do not leave the patient at all. Don't leave them unattended. You stay with the patient because they could have an allergic reaction, and the radiographer has to be familiar with the signs of a mild reaction, moderate reaction, and a severe allergic reaction. So once you're about to give the patient the medication, I would always tell you to give the medication with the door open. That way, if you need someone, you're able to yell and they're more likely to hear you. And once you go to start that injection or giving that patient the medication, you do not leave the patient for the remainder of the exam. As far as the right route, you have to use the right route that is suggested for the medication. Typically, a physician will specify the route by which the drug is supposed to be administered, and we have to be familiar with the terminology associated with the most common routes for the particular drug. When we're administering the drugs, you have to record the name of the drug, the route of administration, and it's particularly important for parenteral routes. And remember, parenteral routes are the routes that are given by injection, typically with a needle and a syringe. So you have to record specifically where that was given, whether it was right arm, left arm, antecubital fossa, brachial, artery, a specific vein, cephalic vein, median cubital vein. If you're able to do that, you want to be as specific as possible. You also want to record the amount of drug that was administered, the time it was given, and the patient's reaction to the drug. Even if there was no reaction, you specifically would want to note that. So the name of the drug, how it was given, where it was given, the amount that was given, the time it was given, and how the patient responded to the drug being given. As far as drug errors, there are errors associated with drug administration, and they're among the most common legal problems in which radiographers can be involved. If an error is made, immediately report the incident to a supervisor or a physician. Do not try to hide the error. Just go and let someone know about it so that ideally it can be corrected. And you want to follow the institution protocol for reporting drug charting or drug administration errors. When we talk about medical abbreviations, you do want to be familiar with the common abbreviations that are used in drug administration, such as IV for intravenous, IM for intramuscular, sub-Q for subcutaneous. The Joint Commission and the Institute for Safe Medication Practices have published lists of unacceptable abbreviations in order to avoid confusion. But the best thing you can do is probably just write out the entire word rather than try to use an abbreviation, so it avoids any potential drug administration errors. As far as the methods of administration or how a drug can be given, there's typically three classes of administration routes. They can either be enteral, parenteral, or topical. When we talk about the enteral routes, you have oral, sublingual, buccal, and rectal. And we talk about, as far as the enteral routes, when you reference the oral route, that is the most common method of drug administration, and it is given by mouth. And typically, the acceptable abbreviation for that is PO, which is Latin for per os, which means by mouth. Typically, the drug is taken into the mouth and then swallowed and absorbed from the GI tract. The sublingual route means that the drug is placed under the tongue and then allowed to dissolve. Now, drugs that are intended to be given sublingually should not be swallowed. The buccal route is when you place the drug against the mucous membranes of the cheek of either the upper or the lower jaw, and again, that drug will dissolve. A common form of a buccal medication would be like a lozenge for your throat or your for a cough. Sometimes they'll tell you to put it in your cheek and allow the medicine to get in and dissolve. And then the last enteral route is rectal, and that is where the medication is given rectally if the patient is not able to take the drug orally. The parenteral routes that they mention, again, parenteral means the drug is administered by a route other than the GI tract. Typically, it is given by injection using a syringe and a needle. There is at least one other form besides using a syringe and a needle, and that would be like medicated eye drops would be an example of a parenteral route, meaning the drug is going in a route other than the GI tract, but it is not necessarily drawn up in a syringe and injected with a needle. But we have 4 different routes of parenteral that involve a syringe and a needle. We have intradermal, intramuscular, subcutaneous, and intravenous. And then the last one that we have is the topical route. And the topical route of administration is when the drug is applied directly onto the skin and it diffuses through the skin and gets absorbed into the bloodstream. Typically, when we think of topical drugs, they're usually in the form of a transdermal patch. As far as the drug administration routes, again, typically oral, sublingual, buccal, topical, rectal, and parenteral. And then they also mentioned the ampule, the vial, the pre-filled syringe, and the infusion drip. When a drug is given and you're using an ampule, typically when drugs are intended to be given parenterally, they're either packaged in an ampule or a vial. So an ampule is a sealed glass container that holds a single dose of the drug and is intended to be used only once. A vial, on the other hand, is either a small glass or plastic bottle that has a sealed rubber cap, and vials are manufactured so that they can contain multiple doses of a drug, and they can be used for either multiple patients, or the same patient can have multiple uses out of that same vial. Typically now, with the way things are as far as not causing cross-contamination and not running the risk of infecting a patient because the rubber cap wasn't sealed or cleaned properly, most medications are given in the form of an ampule. They come in the form of an ampule, not necessarily a vial, but the vial form where it had multiple doses was typically cheaper to buy than the ampule, but unfortunately the cost is just passed directly on to the patient. Some drugs come in pre-filled syringes, meaning there is a certain amount of the drug that's to be given and it comes pre-filled in that syringe. You just simply attach a needle, clean the site, and give the injection. And then the infusion drip is typically where it is in the form of an IV bag, and it is dripped slowly over a long period of time. As far as supplies you need to administer drugs, if it's a parenteral route, typically you're going to need a syringe and a needle. A lot of times in radiology, we use what is called an angiocath. And an angiocath is a safer device compared with other systems to use when performing venipuncture. The angiocath is very similar to starting an IV, meaning that you put the needle in, you thread a catheter over the needle into the vein, and then you retract the needle, leaving the angiocath in place to administer the medication or the contrast media. When they talk about the needle diameters, those are expressed in gauges. And when we talk about a needle gauge, typically the gauge is the thickness or the diameter of the needle. And when we talk about the gauge of a needle, the smaller the number, the larger the hole. Okay, so the smaller the diameter of the shaft or the or the finer the needle is, the larger the gauge number will be. So like a 25 gauge needle has a very small diameter, whereas an 18 gauge needle has a larger diameter. This image here is of a syringe. You can see that they have the plunger, the barrel portion of the syringe, and then we have the tip, which typically is where the needle screws onto that with the tubing. So you would fill up the syringe however much is needed, attach the needle with the catheter, and then push the plunger to inject the medication. Drugs that are intended to be used by parenteral administration are packaged in different kinds of containers. Sometimes they come in the form of a standard hypodermic syringe, an insulin syringe, a tuberculin syringe, or even a pre-filled syringe. When we talk about the parenteral administration, again, these pictures are kind of small on this particular slide, but these images are on page 271. You can see that they have here, they are showing you the bevel of the needle. This is the cannula or the shaft, and then you have the hub. And the same thing, you have different forms of this. This is just a syringe with the plunger and the barrel. This is a tuberculin syringe, but anytime they show you the bevel or the point of the needle, kind of where the hole is for the medication to come out, anytime you're going to give an injection, you want to make sure that the bevel is up. Okay, the bevel needs to be up in order to give an injection. When you talk about drugs that are injected, they have a rapid onset of action because they're absorbed directly into the bloodstream. They're injected directly into the bloodstream typically, so the absorption is quicker and the onset of the drug is quicker. They reference too that all forms of parenteral administration require the use of a needle, a syringe, and a container. Other than, like we said, the medicated eye drops would not. When they talk about venipuncture, again, these pictures are actually found on page 277. These are some common sites of venipuncture. This is the wrist, the palm is up, the palmar surface is up, so the hand is extended with the palm up. Sometimes we actually like to stick in the antecubital fossa. So typically you're injecting either the cephalic vein or the basilic vein. Sometimes though we can inject in the back of the hand. Again, basilic and cephalic vein. It just depends on the patient and what everything looks like as far as which veins have an area that is a little bit straighter. You don't ever want to inject into the crooked portion of a vein. You want to try and attempt to find a straight portion so that the medication goes in and flows smoothly and doesn't have to travel around a bend or kink in the vein. So you want to try and find an injection site that has a little bit of a straight path. When you inject, it is not about seeing the vein as much as being able to feel the vein. I find that injections go a lot better when I can feel the vein versus me being able to see it. Sometimes when you can see it, they're super superficial and they're hard to inject. When we look at the syringe, we've got the barrel of the syringe and the plunger, and it has what's called a hub adapter on there, so that this one just kind of snaps on there, and then this one is called a Luer lock, so it twists on there and actually locks on. Typically, you can inject with any kind of needle. I always used to try and use the butterfly needle so that it was a little bit more comfortable for my patient. When we look at the parenteral injections, I will tell you that the pictures in the book are correct, and these pictures are correct now. They were incorrect initially, but when you give an injection, if it's an intramuscular injection, then it has to be the needle is at a 90-degree angle to the skin. Okay, intramuscular injections are a 90-degree angle to the skin. Subcutaneous injections are at a 45-degree angle to the skin. Okay, so intramuscular, 90 degrees, subcutaneous, 45. We tend to give intravenous injections, which are found on page 275. And I would tell you that an intravenous injection, the range or the angle varies on the patient. The reason that it varies is because some people's veins are very deep and buried, and some people have very superficial veins. So depending on the depth of the vein, the angle of the needle is going to change for what we do, but not for subcutaneous and intramuscular. Intramuscular should always be a 90-degree angle. Subcutaneous should always be 45. Intravenous is the one that varies. When we talk about IV administration or intravenous, there are 3 methods of IV administration. You have a slow injection rate with a single administration route. You can have administration of a drug by intravenous bolus or IV push. And you can have an administration of a large volume of fluid using a drip infusion assembly, which is basically like from an IV bag where it drips a slow, low amount of medication over a long period of time. When we look at venipuncture, typically drugs are placed directly into a vein. The needle length and the gauge depend on the viscosity of the drug or the thickness of the drug, the site that you select, and the specific method of injection. And while you're injecting, you always want to observe the site for extravasation or leakage. Sometimes that is also called infiltration. That is where the medication leaks outside where you intend it to. Typically, the patient will complain of pain when that happens because it's a little bit painful and a lot of pressure when that actually leaks out. If you do have a patient that experiences extravasation, what you do is typically you'll stop pushing the medication and you'll remove the needle and allow the contents of what you put in there. Don't immediately cover it to keep it in. If any of the medication or contrast media will leak out, you want to let it. That way there's not as much left in there. Typically that area will swell, the patient will complain of pain, and we usually try and put a warm compress on there so that the body will reabsorb the contrast media or the medication as quickly as it can. Now, when this says the first step is to remove the needle and apply pressure, I don't disagree to remove the needle, but I would not immediately apply pressure to the injection site. I would allow some to leak out if it could, and then a warm compress to that. What we used to do is just take the water and run it so it was relatively hot and fill a glove with the water and then tie it off and lay the glove over the site, because that way the fingers of the glove itself would kind of mold to the patient and help them not be as uncomfortable as that can be. When we look at venipuncture, the procedure, you want to make sure that you follow all the universal precautions before you attempt any parenteral drug administration. You always want to check 2 patient identifiers, whether it's name and date of birth, last name, medical record number, 2 different factors to give authorization that that is the correct patient. You always want to explain the procedure to the patient and check for any possible allergies they might have. You want to assemble the needed supplies so that you're not trying to run around and gather things as you're giving the injection. And you absolutely want to wash your hands first and then put on disposable gloves. As far as the venipuncture procedure, again, identify your preferred puncture site and wipe with an alcohol swab. Make sure you cleanse the area thoroughly and accurately. You want to apply a tourniquet to the patient. And when you apply the tourniquet, what you're doing is stopping the blood flow so that the vein actually swells, and then you can feel it under the surface. Once you find where you're going to go, you're going to stabilize the vein with one hand, and with the other, you're going to hold the needle with the bevel facing up. Once you're ready to inject, you're going to insert the needle next to the vein at whatever degree angle is required in order for you to not miss the vein. If it's deep, then it probably is going to be a more shallow angle, whereas if it's a shallow vein, well, I guess I shouldn't say that. If the vein is very superficial, your angulation is going to be different than if the vein is very deep. Once you do that, you're going to advance the needle into the vein. And when you advance that needle, you're basically looking to confirm that you're in the vein, and you'll look for a flash of blood. Notice here it says verify the needles in the vein, looking for blood backflow into the tubing, and we do call that flashback. Once you know you're in the vein, you're going to remove the tourniquet and inject the medication, and you're going to inspect the site for any extravasation, making sure there's no leakage of the medication into the tissue. When you're done following your injection, you'll remove the needle and apply gentle pressure to the site with a piece of gauze. And then once you hold pressure for a little bit, you'll dispose of the syringe and the needle properly in the sharps containers, and you'll chart any relevant information about the patient. Again, what drug was given or contrast, how much of that contrast, where specifically was it given, how did the patient respond, all that information that is necessary to be in the chart. If you end up giving medication by drip infusion, that is an IV assembly. A lot of times we'll do this with inpatients because they already have an IV. It is typically used for large volumes of fluid that's being given. Patients will come to the department with their IV pumps already. And you want to pay attention to any IV pump alarms that might go off while you have that patient. You don't necessarily want to silence those alarms. You just want to make sure you see what they are and have the appropriate personnel come and silence those alarms if it's not something we're capable of doing. The IV pump assembly, this is where the pump regulates the flow rates electronically. It is typically programmed to do that. A controller regulates flow rate by counting the drops, and it compresses the IV tubing to adjust the flow. So you, again, be aware of any pump alarms that might go off. And if we're not able or equipped to handle whatever it's telling us, then you want to make sure you get someone who is. In conclusion, it's our job as a technologist to have a basic knowledge of pharmacology and be able to prepare and administer drugs under the supervision of a licensed practitioner. As a tech, we need to be familiar with the actions and precautions that are associated with commonly used drugs or contrast in our field. And venipuncture skills are a common thing in our medical imaging, meaning we are trained. ASRT says that we have to be trained in venipuncture, at least a basic 4-hour minimum class where we are taught to stick. And while it doesn't always have to be in our job description, it typically is mentioned in there, especially if you plan to work in CT or MR, then you absolutely should know how to perform venipuncture, because you'll be doing that quite a bit because many of the exams are ordered with contrast. Always follow the golden rules of drug administration, which are your 5 rights. You want to make sure you have the right drug given to the right patient, the right amount at the right time through the right route. There are different factors that affect the patient's response to a drug, which might not always be something desirable. So again, once you inject the patient, you do not leave that patient until the exam is over and you are walking them out. And once you're done with the medication or contrast administration, you want to make note of any relevant information and put that in the patient's chart to be recorded. All right, and that takes us to the end of chapter 22, which is the principles of drug administration. If you have any questions or comments, make sure that you write those down, the appropriate slide, and I will attempt to answer or clear up any confusion when we meet next. Until then, thank you so much.